We are live now, sir.
Good evening, friends. Now we are going to discuss urea cycle and its disorders. First of all, urea cycle, its stats. Urea cycle is also called Krebs-Hensleit cycle. Other name is ornithine cycle. As I told you in MBBS first year in prof exam, university exam, you should mention at least important points. What are the alternative names? What is the molecular formula? What is the site, organelles, rate limiting enzyme, energetics? Although these questions are also asked in NEET PG, but we are focusing on mainly our university exam. So Krebs-Hensleit cycle, is there any relation with the Krebs cycle? Yes, there is some relation. I will explore that for the time being. Molecular formula of urea. This is NH2CO NH2. And this one nitrogen is contributed by ammonia. You all know that ammonia is very toxic. We eat protein. Protein is made up of amino acid. When these amino acids are degraded, I write here amino acid, common structure to each and every amino acid is this R. So this carbon, hydrogen, oxygen, we are not worried about that. But we are worried about ammonia. Ammonia is toxic. And this toxicity is taken care by liver. Liver is the main organ of metabolism. Liver convert this ammonia to urea. So urea cycle occur in liver. Question also asked. And which compartment? Few pathways occur both in mitochondria and cytosol. And mnemonic was hug, pyare. Hug, pyare. Yes, H for heme synthesis, U for urea cycle, G for gluconeogenesis, pyrimidine synthesis. So these pathway occur both in mitochondria and cytosol. So mitochondria plus cytosol. What is the rate limiting enzyme? That is CPS1, carbamoyl phosphate synthetase 1. And very important activator of CPS1 is N-acetyl glutamate. Okay. So one nitrogen contributed from ammonia, carbon is contributed by CO2, and the second nitrogen is contributed by, yes, please comment, second nitrogen is contributed by aspartate. Mnemonic is aspartate participate in urea synthesis. Another mnemonic you can make urea, urea, A for ammonia, A for aspartate. Means two nitrogens are there and both nitrogens are contributed by A for ammonia, A for aspartate. This is formula, this is site, this is organelle, rate limiting enzyme, energetics I will discuss after this pathway. Carbon dioxide bind with ammonia. We want to detoxify ammonia. Although we should write ammonia first and CO2 second. But I have deliberately written CO2 bind with ammonia to form carbamoyl phosphate. And the name of this enzyme is CPS1, carbamoyl phosphate synthetase 1. Carbamoyl phosphate synthetase. You all know the difference. Yes, you all know the difference between synthetase and synthase. Synthetase ATP is required. So in this, two ATPs are required. Two ATPs are converted to 2 ADP. Clear? This carbamoyl phosphate react with ornithine. To form citrulline. Now you will remember the sequence. Why I'm telling you to remember sequence? All the metabolic disorder related to urea cycle can be solved, question can be solved by this sequence. So C. Although these pathways are occurring in mitochondria, but start with C. So CO2 bind with ammonia to form carbamoyl phosphate. Carbamoyl phosphate bind with ornithine to form citrulline. And the name of enzyme is OTC, ornithine transcarbamylase. OTC. Citrulline come out of the mitochondria. Now in cytosol, this citrulline is in cytosol. This aspartate which was present in mitochondria come out of the mitochondria with the help of citrin transporter. So citrin transporter is for aspartate, not for citrulline. This is important point. So aspartate bind with citrulline. Mnemonic for that, AS. AS. When aspartate will bind with citrulline, it will form argininosuccinate. A for arginino, S for succinate. Okay, so AS sequence, again I am repeating, sequence is important. You must remember the sequence. You will appreciate the importance of sequence shortly. Now, the name of enzyme is argininosuccinate synthetase. Synthase, no ATP used. Synthetase, if you pronounce synthetase, little bit more energy is used. So synthetase, ATP is used. In this, ATP is converted to AMP. If you have any doubt, you can ask me. Okay, AMP. When ATP is converted to ADP, one high energy phosphate is used. When ATP is converted to AMP, two high energy phosphates are used, equivalent to 2 ATP. So I can say 2 ATP used here, 2 ATP used here, and 2 ATP used here. Now I go back, and yes, now I do energetics. This is controversial, particularly for NEET PG entrance exam. In your university exam, you will also point out that CPS1, carbamoyl phosphate synthetase 1, used 2 ATP, and this argininosuccinate synthetase utilize 1 ATP or involve 1 ATP, but use 2 high energy phosphate, 2 high energy phosphate equivalent to 2 ATP. So net utilization of ATP is 4 ATP. Okay, so if they ask directly how many ATPs are involved, directly, yes, 3. But net utilization is 4. Okay, so 4 ATP used. Mnemonic is urea. Yes, 1, 2, 3, 4, 4 letters are there. So definitely you can easily remember 4 ATPs are used, or energy equivalent to 4 ATPs are used. Now, argininosuccinate is converted to fumarate and arginine. Very simple to remember. Arginino is converted to arginine. Succinate is converted to fumarate. I link it with Krebs cycle at this point. Yes, succinate in Krebs cycle, succinate is converted to fumarate by succinate dehydrogenase. We all have learned that succinate is having 4 carbon, fumarate is having 4 carbon. They are easily converted into each other. So succinate can be easily converted to fumarate. So you can say this succinate is converted to fumarate as released, and this arginino part is converted to arginine. And this fumarate is connecting link between urea cycle and Krebs cycle. Name itself, although the origin of name of this Krebs-Hensleit cycle is different, but question is asked, the connecting link between Krebs cycle and urea cycle is, yes, please do comment, fumarate. Connecting link is fumarate. Okay, so why it is connecting link? Because this fumarate will go to Krebs cycle, and this fumarate will be converted to malate. Malate will be converted to oxaloacetate. Krebs cycle is occurring in mitochondria. It is occurring in mitochondria. And this oxaloacetate by transamination, you all know that if I attach ammonia to oxaloacetate, it is converted to aspartate. The only difference between aspartate and oxaloacetate is ammonia. Okay, even if you don't remember this at this time, just have an idea. Okay, it is converted to aspartate. And this aspartate, yes, this aspartate take part in urea cycle. I just told you that, I repeat it, CO2 bind with ammonia to form carbamoyl phosphate, bind with ornithine to form citrulline. Citrulline come out, Aspartate come out of mitochondria, aspartate and citrulline bind. So aspartate is coming from oxaloacetate. So question, connecting link. Yes, you can answer connecting link between urea cycle and Krebs cycle. That is fumarate. Fumarate. Second question, connecting amino acid between urea cycle and Krebs cycle. Please do comment. Aspartate. So if they ask about amino acid, you will point out aspartate. Okay. Now this arginine is converted to ornithine by enzyme arginase. Arginase. Okay, and water is joined, hydrolysis occur. Yes, hydrolysis means cut a bond with addition of water and this urea is released. So you can say arginine is converted to ornithine and urea. This ornithine go back to mitochondria. This ornithine go back to mitochondria with the help of enzyme. Oh, sorry, with the help of transporter, ornithine transporter, not enzyme, ornithine transporter. Okay, so this ornithine was the starting point, and in the end, this ornithine is again produced. So this is ornithine. That's why it is called ornithine cycle. So urea cycle, Krebs-Hensleit cycle, ornithine cycle. Yes. So this is urea cycle steps. Fast CO2 bind with ammonia, carbamoyl phosphate to form citrulline, again joined with ornithine to form citrulline, citrulline come out, bind with aspartate to form arginosuccinate, arginosuccinate produce fumarate and arginase produce urea. Now, this was CPS1, which is present in mitochondria and very important activator or allosteric activator, obligate, write down, obligate allosteric activator is N-acetyl glutamate, NAG, NAG. Okay, NAG. Yes, N-acetyl glutamate is activator. Obligate. Why I use the word obligate means this is required for its action. Without this NAG, you can't do this CPS1 action. CPS1 is present in mitochondria. CPS2. So this is not related to urea cycle, but you will discuss or you will remember at the same time because urea cycle defect, we will use this pathway. Pyrimidine pathway occur both in mitochondria and cytosol. First step is glutamine bind with CO2 by CPS2, carbamoyl phosphate synthetase 2. So CPS2 is present in cytosol. So pyrimidine synthesis, the first step occurring in cytosol. Urea cycle, the first step occurring in mitochondria. So I compare here. CPS1, CPS2. CPS1 is present in mitochondria. CPS2 is present in cytosol. CPS1, urea cycle. CPS2, pyrimidine cycle. If you want to remember, you can make mnemonic that DI, die. Die matlab 2. Die matlab 2, CPS2, and it occurs in 2 compartments. So it will help you to remember. So pyrimidine synthesis. Okay. This pyrimidine synthesis, glutamine bind with CO2 to form carbamoyl phosphate. This carbamoyl phosphate by multiple steps form orotic acid, then pyrimidine base. Okay. I leave this pyrimidine synthesis at this time. Again, come to urea cycle. Now I discuss urea cycle defects. In urea cycle defect, first defect is CPS1. Carbamoyl phosphate synthetase 1. If this is defective, then ammonia will not be detoxified. Ammonia will not be detoxified. Ammonia will increase And if ammonia increases, that is called hyperammonemia. So hyperammonemia type 1, ammonia is increased. What are the symptoms? I will discuss shortly with concepts. Ammonia is very high in this patient. If OTC, ornithine transcarbamylase, is defective, this is most common defect, most common urea cycle defect. Question has been asked, urea cycle defect. Whatever I am saying, question has been asked. That doesn't mean that it's for NEET PG only. That is, you may highlight this point in your university exam and definitely you will get extra eyes. Yes. So most common urea cycle defect, ornithine transcarbamylase is defective. If this enzyme is defective, this step will not occur. Carbamyl phosphate will accumulate. This carbamyl phosphate will diffuse out of the mitochondria, and this carbamyl phosphate will enter, yes, pyrimidine synthesis and will produce orotic acid urea. So question is asked, ornithine transcarbamylase defect lead to orotic acid urea. Other than that, pyrimidine in urine. Other than that, ammonia will be increased. Definitely, this ammonia will not be metabolized, so ammonia will increase. So this is hyper, yes, ammonia increases. So hyperammonemia type 2. It is X-linked recessive. In few literature, it is written that it is X-linked partial dominant type 2 hyperammonemia. Clear? In this, carbamyl phosphate will increase, ammonia will increase, citrulline will increase or decrease. I told you that to remember the sequence of all these pathways. The purpose is that in clinical scenario, they will say the patient is lethargic, poor feeding, failure to thrive, convulsions are there, and they will give lab finding. In lab finding, they will say orotic acid is increased. Orotic acid is increased. Citrulline is decreased. Definitely, citrulline will not be synthesized, so it will be decreased. So if you remember the sequence, you will be able to find the answer very easily without the clinical scenario or clinical symptoms. Okay, but we will remember the clinical symptoms also for the time being. Yes, this is most common urea cycle defect. It is X-linked recessive or X-linked partial dominant. Ammonia is increased, orotic acid is increased, orotic acid urea, and pyrimidine in urine. Now, this citrulline is metabolized with the help of aspartate. If argininosuccinate synthetase, this enzyme is defective. If this enzyme is not there, then this citrulline will not be converted to argininosuccinate. And citrulline will increase. That is called citrullinemia. Citrullinemia type 1. So if this enzyme is deficient, then it is type 1 citrullinemia. But we found that few patients in which citrulline is increased, in those patients, this enzyme is normal, but the defect is citrin transporter. I told you citrin transporter don't transport citrulline, it transport aspartate. If this is defective, again, this aspartate would not be available for citrulline. So citrulline will not be metabolized, citrulline will increase. So again, citrullinemia, yes, and this is type 2, citrullinemia type 2. So type 1, type 2, citrullinemia. Now, arginosuccinate is converted to arginine and fumarate by arginosuccinate lyase. Arginosuccinate lyase. If this arginosuccinate lyase is deficient, then argininosuccinate will increase, and this is argininosuccinic acid urea. Argininosuccinic acid urea. Yes. Any doubt, any question? You can comment. Yes. Argininosuccinic acid urea. Mnemonic for this is RST. LMNOPQRST सीक्वेंस याद रखेंगे। आर, AR को मैंने R रख लिया याद। S4 सक्सिनिक एसिड यूरिया एंड T4 ट्राइकोरेक्सिस नोडोसा। Yes, typical image based question sometimes you will find. Yes, tufted hair, alopecia would be there. So this is argininosuccinate lyase defect. Now the next enzyme defect is arginase. If arginase is deficient, yes, then arginine will increase. Arginine will increase. That is called argininemia. Argininemia. Yes. Mnemonic again, RS. RS. R for AR. S for spastic dysplasia. Scissoring gait. Okay. And in this, there is least hyperammonemia. What does it mean? You will find that if defect is in the initial part of urea cycle, ammonia would be very high. That is why we said hyperammonemia, and this was type 1. Then defect at this point, OTC, again ammonia was very high, but not as type 1. But it was very high, hyperammonemia type 2. After that, yes, as the path will progress, hyperammonemia would be decreased, means the concentration of ammonia would be less increased, okay, because the intermediate product will be increased. Just like citrullinemia, citrulline is increased, this is increased, this is decreased, okay. So till now we have discussed these urea cycle defect. Now one question has been asked, or this is important, ornithine transporter defect is triple H syndrome, HHH. If this transporter is defective, ornithine will not enter the mitochondria, so ornithine will increase, so hyperornithinemia. I know this is difficult to remember, even pronunciation is also difficult, लेकिन if you will revise it once or twice, क्योंकि ये यदि मैं if I talk about the university exam, तो हमेशा क्वेश्चन आता है यूरिया साइकिल डिफेक्ट पे क्वेश्चन आता है, इंडिविजुअल यूरिया साइकिल डिफेक्ट OTC डिफेक्ट पे क्वेश्चन है, और you will find the long question also, and clinical scenarios are also being asked, and I will tell you how these clinical scenarios can be solved with the help of this pathway only. When ornithine will not enter, definitely urea cycle will be disturbed and ammonia will not be detoxified. So ammonia will increase. So hyperammonemia, hyperammonemia. So 1H is for hyperornithinemia, 1H is for hyperammonemia. Third H is homocitrulinemia. ये ध्यान से देखना है. If ornithine will not reach the mitochondria, this carbamoyl phosphate is searching its friend. Yes, where is my ornithine? But ornithine is not there. So it will bind with lysine. Yes, lysine से bind किया, चल तू ही आ जा. Lysine से bind किया और बनाया homocitruline. So homocitrulinemia, triple H syndrome, hyperornithinemia, hyperammonemia, homocitrulinemia. So in this way, you can solve many questions, clinical scenario by this flow chart. Now I am coming to solve question. Just like if only and only ammonia is increased. Yes, you can comment. If only and only ammonia is increased, type 1 hyperammonemia. If ammonia is increased, orotic acid is increased, pyrimidine is increased, that hyperammonemia type 2. If citrulline is increased and argininosuccinate is decreased, this question has been asked twice, okay, then it is, yes, citrullinemia. Now, interrelation, I have already explored that this argininosuccinate is converted to fumarate, and this fumarate enter the Krebs cycle, and this oxaloacetate is converted to aspartate, and this aspartate, yes, this aspartate goes and yes, I will draw here, okay, because Krebs cycle is occurring in mitochondria. Yes, so aspartate participate in urea cycle, provide nitrogen, ammonia. Okay. Yes. Now we discuss over here how you will remember the symptoms of urea cycle defect. First, in urea cycle defect, ammonia is increased. Whenever ammonia is increased, ammonia bind with alpha ketoglutarate. Ammonia bind with alpha ketoglutarate to form glutamate. This glutamate bind further with ammonia to form glutamine. Glutamine. Okay. So one question is asked that in hyperammonemia or urea cycle defect, which intermediate of Krebs cycle, this is Krebs cycle, which intermediate of Krebs cycle is depleted? Can you comment? Which intermediate? Yes, alpha ketoglutarate is depleted. Got the point? This glutamate is increased. Glutamate is converted to GABA. GABA is inhibitory neurotransmitter. So if in brain ammonia is increased, this ammonia bind with alpha ketoglutarate. This will be depleted. Krebs cycle will not occur. Energy will not be produced. There would be encephalopathy. So I write here encephalopathy. And this encephalopathy is due to which organ? Hepatic, liver defect. Liver is not able to synthesize urea. That's why this encephalopathy is occurring. So you can say hepatic encephalopathy, one cause. Yes, means liver is not able to detoxify. And due to this, yes, Krebs cycle is not occurring, energy is not produced, brain, yes, is affected. Glutamate is converted to GABA. GABA is inhibitory neurotransmitter. It will inhibit, yes. Glutamine, it will produce osmotic gradient and there would be edema. So you will find that in these patients, tachypnea would be there. I make a conceptual mnemonic. If suppose energy is not there, means oxidative part is not occurring in brain, then center will be stimulated, get oxygen. To get oxygen, yes, tachypnea would be there. Yes, increase respiratory rate. When increase respiratory rate, there would be CO2 washout. Yes, H2CO3 would be decreased. Means there would be respiratory, yes, comment, respiratory alkalosis. Respiratory alkalosis. So pH would decrease or increase? pH is increased. Okay. So in clinical scenario, you will find that the patient is having feeding difficulty, lethargy. Patient is having feeding difficulty, lethargy, failure to thrive. Yes, convulsions, coma. These are common symptoms in the clinical scenario when they will ask about the questions on urea cycle defect. They will give these symptoms, but these symptoms are common to septicemia also. These symptoms are common to other inborn error of metabolism also. So yes, you will do lab diagnosis. You will do lab diagnosis. In lab diagnosis, first of all, you will find increased ammonia. In all urea cycle disorder, ammonia will be increased. Now, sometimes in clinical scenario and questions, you will find that they will not mention ammonia. They will give increased glutamine. Why I'm telling you these scenario and questions? Because many university exams are now asking objective question. So that's why I'm taking care of those objective questions also. Okay. So whenever ammonia is increased, glutamine is increased. So sometimes you will find increased glutamine. pH, if it is increased, that is urea cycle defect. If it is decreased, it may be organic acidemia. Okay. And gold standard, is tandem mass spectrometry to detect urea cycle defect. Now we come to treatment of urea cycle defect. First is arginine. You all know arginine is essential amino acid or semi-essential. Yes, semi-essential. Few literature says that in childhood it is essential, but in adults it is semi-essential. So both points are correct. So in children it is essential, in adulthood it is semi-essential. So if urea cycle is not occurring, if this is defective, arginine will not be synthesized. So arginine must be supplied from diet. So arginine should be supplied. But contraindication in arginase deficiency. If arginase is deficient, if this enzyme arginase is deficient, okay, this is deficient. Yes, never ever give arginine. Got the point? Now, secondary treatment. What are the treatment? Acylation therapy. In this, we give sodium benzoate. We have already discussed previously in previous sessions that benzoic acid bind with glycine. Glycine bind with benzoic acid to form hippurate. That question has been asked on this, that benzoic acid bind with glycine to form hippurate or hippuric acid, which is excreted in urine. Okay. So glycine is the simplest amino acid. So simplest amino acid can be synthesized in our body or not? Yes, it can be synthesized. So we found that if ammonia is high, we want to decrease ammonia. Ammonia will bind with CO2 plus one carbon unit will join to form glycine by glycine synthase. So glycine synthase will synthesize glycine. Glycine will bind with benzoic acid. Benzoic acid will produce hippurate. It will be excreted. In this way, you can decrease ammonia. So this is acylation therapy, first by sodium benzoate or benzoic acid. Second is phenyl butyrate. Phenyl butyrate. This is prodrug. Means in our body, this phenyl butyrate is converted to phenyl acetate. Phenyl acetate will bind with glutamine. And it will make phenyl acetyl glutamine. Phenyl acetyl glutamine. Okay, acetate से क्या बन गया? Acetyl glutamine. Okay, it is water soluble. So it will be excreted. So in this way, you can treat urea cycle defect. Now, again, I am repeating the sequence. You must know why I am telling you this again, because questions are asked, clinical scenario are asked, OSCE pattern is asked, in which you will find this. So C. Okay, C. This citrulline bind with aspartate AS. Now, succinate release as fumarate, arginino as arginine, then arginase ornithine. Okay. Now, if question is asked in a patient, ammonia is increased, argininosuccinate is increased, but arginine is low. What is the defect? Please do comment. Yes, the answer would be argininosuccinate lies. So, clinical scenario you will find in those lab diagnosis would be given. They will give these metabolites which are increased. You will find the answer by remembering this cycle. Thank you for patience listening. Best wishes for your exam.